grading, I will open up the statistic column for you guys to see, yeah.
Will we get the exam that we wrote on?
You will not get the exam that you wrote on.
Oh.
So you will get your Scantron where it has your right and wrong answers, yes.
So can we like write down all the questions if we're like, just so like for studying for the final?
No, you can't, you've gotta, just listen and pay attention. I mean, we want to protect the integrity of the exam. We don't write entirely new exams, for every semester. So some of the questions we reuse, so we don't want them floating around out there. So when we do the exam review, you have to have nothing on your table, all the recording things need to be put away. You can only have a piece of paper, your Scantron, and something to write with, so you can take a couple notes or mark off ones you got wrong versus ones you got right. But and then, of course, after next Monday, if you want to talk more or go a little bit more in depth over an exam, please let us know. We are welcome to do so. But yes.
At that point, can we have the exam?
Yes.
Okay.
At that point, you can. I'm just not going to bring them all and then try and collect them all. It's just too much. Too big of a class. Okay, guys, well, we're moving on to new content. We're still going over some basics here. We're not until, this week is kind of how cells can go bad. And remember, whenever we're talking about pathophysiology, it ultimately comes down to what's happening inside of a cell. So we talk about heart disease, it's what the effect is on cardiac cells, and what does that mean for the entire organ. But right now we're just looking at different ways that cells themselves can be injured. Starting next week, we're going to spend a full day next Monday on infection and then antibiotics to treat infections. Then we actually start on like an actual system. We get the pulmonary system after that. Then we get a little bit more regular as far as we look at a system, what goes wrong, the drugs that go along with that. So depending on your biology background, your anatomy and physiology background, some of this stuff may be stuff that you've seen quite a bit of. So hopefully some of it is at least a little bit familiar. Okay, so we're looking at cellular adaptation. How do cells change and adapt in response to different stimuli around them, in response to maybe toxins that are in the environment, other disease processes? These are some of the ways that cells can adapt. And whenever we're looking at these, we need to look at the physiologic adaptation versus a pathogenic adaptation. And our 5 basic kinds are atrophy, hypertrophy, hyperplasia, dysplasia, and metaplasia. And we're going to go through these one by one. But this is a nice little picture going an overview of what those different cells would look like. Okay, atrophy. Atrophy is the shrinkage in cell size, but not number. So we're not losing cells, but the cells of an organ or the cells in an area are becoming smaller. So your entire organ can shrink. You can have brain atrophy, you can have muscle atrophy. So we can have physiologic or pathologic. Physiologic means it's kind of something that expected that happens. It's not a disease process. And then we have pathology, a disease process. So physiologic can occur with development. For example, you guys remember the thymus gland from A&P? Where does that sit?
On the heart.
Yep, it kind of sits over the heart. Very active when you are young. Once you get to be an adult, it stops being useful to us and it just kind of shrivels up. And that's totally normal. Pathologic. You also can have pathologic. Can be due to decrease in workload, muscles especially. Can be due to pressure. It can be due to use or lack of use. Alterations in blood supply. Alterations in nutrition. Hormonal stimulation or removal of hormonal stimulation. And nervous system stimulation. So there's lots of different reasons that cells can atrophy. As we start going through different disease and body systems, we'll talk a little bit more about specifics going along with this. But in general, the cells contain less endoplasmic reticulum. And you remember your ER is where you have tissue and protein synthesis occurring. So these cells are smaller and they're not doing as much of what they should be doing. They also have fewer mitochondria. What are our mitochondria doing? Powerhouse, there we go, creating ATP. So fewer mitochondria, these cells are smaller and they're just not doing as much of the things that cells normally do. Hypertrophy is the opposite. We have increase in cell size, but not the number of cells. Our entire organ can increase in size when this happens. This can happen in the heart and in the kidney. Once again, we have physiologic versus pathologic. Physiologic, increase in muscle size, getting swole. Do you even lift, bro? My sister at the age of 41 decided that she wanted to be a competitive bodybuilder. So she now works out 3 hours a day. And she's quite muscular. She'll kick all of our butts. But yes, so this is physiologic. If you use certain muscles more, they're going to increase in size. The uterus in pregnancy. Uterus gets huge compared to what it normally is when it's not pregnant. And this is all physiologic. This is a normal response to different things that are going on. Pathologic. Cardiac hypertrophy with hypertension. Hypertension we're going to be talking about after this next exam. We do a whole section with a whole bunch of stuff about the heart because the heart is so important and there's so many disease processes that go on with it. But as a brief overview, hypertension, that's increased blood pressure. If your heart has to pump harder because, especially the left ventricle, to push out blood because the pressure in the aorta is higher, those cells are going to be working harder. And it's usually not a good thing when you have the cardiac cell size increasing in response to hypertension, because it's not good old-fashioned exercise that's doing it. In this case, we have an increase in our ER, in our mitochondria, as well as in the size of our plasma membrane, which would make sense. If the cell itself is bigger, you need more plasma membrane to cover it up, more surface size. Hyperplasia. This is the increase in the number of cells, and it can happen hand in hand with hypertrophy. So you can have cells that are undergoing in an area that are undergoing both hypertrophy and hyperplasia. They're growing in size and growing in number. Note that cells that do not divide, such as heart cells, we can't have hyperplasia. Once again, physiologic versus pathologic. In physiologic, we have something called compensatory hyperplasia. This is an adaptive process. One of the best examples is the liver. You can remove 70% of the liver, and as long as the rest of your body is functioning and healthy, it will regenerate. If we can unlock that secret for the rest of our cells, it would be great. Yes?
So if the red cells don't divide, how does the little baby heart become a person?
They're tiny little cells when they start. There's a certain part where like stem cell development where you're getting still a reproduction of cells, but it's very early in development that turns off. So yeah, liver is great. It can regenerate. It can regenerate in 2 weeks. It's crazy. So we have seen, especially in the pediatric population, little kids who need liver transplants. Sometimes we can take a chunk from their mom or dad and give it to a kid. Mom and dad's regenerates, and then the little one that gets it grows along with them. Yes?
Was the person at risk, like who that you're cutting a piece of liver out? Like, are you cutting away processes?
So are you cutting away? Yes. So you're putting the person at risk. So whenever we do a living donor situation, kidneys we can do living donor, and liver we can do liver donor, and small bowel we can do liver donor or living donor to do that. Yes, there's absolutely risks to anyone who's taking out part of their body. So the patient, number one, has to do a match, make sure that they have a match of surface proteins, blood type, and we'll talk about organ transplantation in general next semester. But lots of things to match. Also, since it is an elective procedure, making sure that that person is healthy enough to undergo this procedure. So there'll be extensive testing of their cardiac status to make sure that they're physiologically strong to handle being hacked open and a chunk of your liver cut out. And they have figured out strategically like which parts of the liver that you can take out and not have too much of an issue and it will regenerate. So yeah, but that's a great question. Just making sure that we know that the person is healthy enough to donate. A callus on your skin from taking all those notes. right? Got a little callus on your skin, especially after that exam. And that's increase in skin cell production. It's in response to the fact that you're doing an increased amount of activity in an area. Hormonal hyperplasia, especially their estrogen-dependent organs, like the breast and uterus, are very tiny cells and not very many cells until estrogen is provided. Then once estrogen removes, there's also shrinkage. Good question?
So the compensatory hyperplasia, how do you define that as, it's just doing it when it's needed, or?
Compensatory hyperplasia, it's increased growth of cells because there is a direct stimulation that's telling it to, but it's not a disease process. We can also have pathologic hyperplasia. One example of this, if you have imbalanced hormones, females, your endometrium can have hyperplasia. So people with imbalanced hormones can sometimes have excessively heavy periods because the hormone levels allow for very thick endometrium to develop, and then when it's shed, we have heavy bleeding. So that is an example of that. So metaplasia and then dysplasia are kind of part of a continuum. Metaplasia is reversible replacement of one mature cell type with another. So here we've got our normal epithelium. I kind of changed the order when I was playing them, so I just rearranged the order of those two cells. Because metaplasia and dysplasia is worse. So I wanted to put dysplasia last and change it around. Okay, so neither of them are good. So these are things, our two biggest examples are the cervix, mostly in response to human papillomavirus, HPV, to develop cervical cancer, and also the lining of the respiratory tract from either smoking or depending on the work environment, if you're exposed to certain pollutants in a factory setting or some other kind of industrial setting. It's the epithelial cells epithelial cells start to change, and it's really more of a protective mechanism. Initially, with the metaplasia, we have a replacement, and remember, you may have heard stuff about how your cilia are killed off when you're smoking. So those cilia, these are lung epithelial here, which normally push up things so that you can cough it out more easily. So we've got cells that are a little bit hardier here. They're a little bit less likely to get damaged, but they don't function as well as they could. So metaplasia, replacement of one mature cell type with another, sometimes less differentiated cell type. Differentiation, meaning this is an epithelial cell from the lung, this is a beta cell from the pancreas. Those cells have certain characteristics, they're differentiated. And these cells become less differentiated, meaning that they don't function exactly the same that the original cell does, and usually have fewer functions. Now you can go back, if you quit smoking and you've developed dysplasia, or metaplasia, if you have early signs of metaplasia in the cervix and you clear the virus, the human papillomavirus, you can go back to these normal epithelial cells. However, if you have persistent injury, or if the initial injury is severe enough, you can develop dysplasia. So dysplasia is abnormal change in size, shape, and organization of mature cells. So if you notice in metaplasia, it's one cell type replaced by another, but they're pretty uniform. You pretty much have two different types of cells right here, right? In dysplasia, the cells that are in here being replaced, they have a lot of differences. They're very poorly differentiated from each other as well as from the cells that they initially came from. And this sets up a situation where it's much easier for cancer to develop. Dysplasia is not a true adaptive process, sometimes termed atypical hyperplasia because of the fact that it very commonly can lead to cancer development. And like I said, our two biggest areas where we know this to be true: the cervix and the lining of the respiratory tract. Yes?
So, what would that look like
Clinically, so with dysplasia is really a precancerous cell. So a lot of you ladies in here may have had pap smears at this point in your life. If not, you probably will sometime soon. What we're looking at is whether or not, when we take a scrape of the cells and we know we're cancerous, it's at the border between the mature and immature cells. We know that if you scrape along that border, you can look at cells, put them on a slide, and a laboratory technician actually looks at them. Actually, they may probably have computerized things that'll look at it now, and says there's something abnormal going on here. This is before it turns to cancer, so you're not going to get any symptoms physiologically. This is catching it before it gets bad. Now, if you catch this early, there's things you can do specifically for the cervix: colposcopy, some cryogenic freezing of the cervix to remove the cells that are precancerous in the hopes that they don't come back, and then continued monitoring. So really, this is not going to be seen very easily, and especially in the respiratory tract, we don't do, the equivalent of a pap smear in the respiratory tract. It's really hard to do something like that. So yeah, we're not going to see anything clinically with it. Yeah.
So it's a virus or the cancer that will trigger the organ to start producing these cells?
It is the virus that triggers. It's that is specifically for the cervix. The human papilloma virus is incredibly irritating. There's a lot of correlation between viral infections and other types of cancers as well. But cervical cancer really is an STD. And there's a lot of controversy with the long-term effects of the HPV vaccine that's coming out. There may be a correlation with the vaccine causing premature ovarian failure, which is a big consideration. Before that, I mean, if anyone wants to argue vaccines with me, I'm all for it. Keep going. My sister-in-law decided not to vaccinate my niece because her life coach said that she shouldn't. So that was a fun Christmas. The vaccine. So the rates of cervical cancer, cervical dysplasia, since the HPV vaccine has been introduced, have plummeted, and it is just an amazing thing to see. But that is a concern, the premature ovarian failure, because you're talking about potentially, and when this study just came out within the last week. Correlation is not equal causation. Is there actually a correlation? Is there actually something that we need to worry about with this, which then we need to investigate more fully? But yes, in short, cervical cancer is essentially an STD. Yes.
So, are you saying the way it works is that something like HPV will irritate the cells in the cervix and make them dysplasia?
Dysplastic. Yes. Dysplastic. Yes.
Which will then turn into cancer?
So it can. So you get infected with HPV, and 70% of adults have at least at some point in their lives carried HPV, at least one strain. There are multiple strains of HPV. There's two for sure that we know are very highly correlated with cervical cancer. There's another two that are very highly correlated with genital warts, which is not nearly as serious as cancer, but incredibly disgusting. Well, I'll show you pictures next semester when we talk about STDs. I got a whole collection of really gross pictures for you guys. So you get exposed to this virus via sexual activity, and your body can hang out in the cervical area in those epithelial cells, and your body can get rid of it and have really no untoward effects. It can linger for a little bit longer if your body doesn't naturally take care of it and cause some dysplasia, maybe even some metaplasia. Once again, these are still reversible if you remove the offending toxin or irritant, in this case the virus. But we don't have treatments for viruses yet, right? I mean, we've got antiviral drugs that can suppress viruses, but it's not like we have antibiotics for viruses. We can't just kill a virus like we can with a lot of our bacteria. So yes, depending on how a person's body reacts, that continued stimulation, if that HPV isn't cleared or if it's irritated those cells enough, there can be enough changes in those cells that we have cancer that occurs.
You said that the dysplasia dysplasia is worse than metaphasia, but it's still reversible.
Still reversible, yes. But instead of just having, one type of cells being replaced with another type of cells, now we have a lot more disorganization. And we'll talk about a lot more next semester when we talk about cancer. But cancer is essentially a genetic disorder. We've got genes that are altered that make them grow, the cells grow uncontrollably. And this is one of the ways that you can set up a situation where cells mutate and then develop the ability to grow in an uncontrolled fashion. Mm-hmm.
For which one of them was it metaphasia or dysplasia? You said it was initially a protective measure?
So with the dysplasia, it's initially a protective measure. So instead of your more delicate epithelial cells being there, maybe in the lining of the lungs if you're a heavy smoker, you've got cells that are a little bit more hardy, a little bit better to withstand constant irritating smoke, but they've now lost their cilia. They no longer push out. So while they're more protected, they're not doing as much as they should. So, 40-year-old females, pap smear indicates abnormal changes in the shape and organization of cervical cells. What term would you use to identify this? Dysplasia. There you go. You got this. All right. So we got some dysplastic cells that need to be addressed. If we catch it before it becomes cancer, we now saved this person a lot of trouble. All right. So cellular injury. This is the big picture here, okay? So we've got our normal cell. Here's our nice happy cell here. And then we've got some kind of stressor. It could be the HPV virus, it could be smoking, it could be a lot of other stressors, and the cells adapt. So we talked about all those ways that a cell can adapt previously, those first couple slides. And like we said, metaplasia is more in dysplasia, maybe not adapting, maybe poorly adapting, okay. So if we either have the inability to continue to adapt or a stimulus that is so strong that it doesn't allow the cell time or ability to adapt, then we have cell injury. If it's a reversible injury, mild transient, we get rid of the offending toxin or stressor, we can go back to our normal cell. If it is severe enough initially, or if it is continuous and progressive injury, then we have irreversible injury and we're going to have cell death, and those will either be necrosis or apoptosis. You guys have heard both those words before? Apoptosis, you guys know apoptosis? Programmed cell death. Programmed cell death. So that's when a series of events is initiated within the cell, sometimes just due to the general old aging process. Cells only reproduce themselves so many times and then they're like, I'm done. Or in stimulation to other things in the environment. And we will, later in this lecture, go more in depth into the difference between cells that are undergoing necrosis and cells that are undergoing apoptosis. Okay, so hypoxic cell injury is one of the most common types of cellular injury, where we have hypoxia, which is a lack of sufficient oxygen. This is the most common cause of cell injury. Ischemia is reduced blood supply. Now you can have hypoxia without ischemia, but you can't have ischemia without hypoxia. So you can have a situation where you have blood supply that is adequate, but the delivery of oxygen or the utilization of oxygen is not sufficient. Ischemia, when we're thinking more of a blockage or a decrease in blood flow. So a heart attack, also called a myocardial infarction, an MI, a stroke.
Can you say that again? You said you can't have hypoxia without ischemia, or the other way around?
So you can have hypoxia without ischemia. So you can have a situation where you have adequate blood flow, but maybe that blood that is flowing because you're anemic isn't carrying enough oxygen. Or maybe the cell has sustained some sort of damage that even though we have enough oxygen in the area, the cell isn't able to utilize it correctly. But ischemia is a reduction in blood supply. And if you're ischemic, you're going to have hypoxia. Because if you don't have enough blood, that's the only way to get oxygen to tissues. And then we have anoxia, complete lack of oxygen. So that can be to a particular area. If you have a giant heart attack, a big clot that forms in a vessel, you can have an entire area of cardiac tissue that is getting no oxygenation, no blood supply. You can have global anoxia if you're strangled, if you have complete stop of your cardiovascular, cardiorespiratory system. So, this is a fun chart. Lots of really good information in here. What happens to the cell when we have a obstruction or cessation of blood flow? Ischemia. Obstruction or cessation, we have some ischemia. We get decreased mitochondrial oxygenation. If the mitochondria are not getting enough oxygen, we are drastically reducing the ability to produce ATP. So we have decreased ATP and a couple things happen. Number one, let's look over on this side here. Our sodium potassium ATPase pump stops working. You guys all remember that pump from A&P? Super, super important pump in your body. Little tiny proteins that are doing such an important thing throughout your body right now as you're sitting there. This is making sure that your cells don't swell, because as long as you're maintaining the balance of electrolytes across the membrane, you maintain homeostasis of your cell. When your sodium potassium ATPase pump stops working, your intracellular sodium increases. Your extracellular potassium increases, and your intracellular calcium increases. The intracellular sodium and the extracellular potassium are all due to the ATPase pump. The intracellular calcium is really more due to the fact that the mitochondria, one of the jobs of the mitochondria besides being the powerhouse, is to suck up extra calcium. Calcium in small amounts in the cell is good. Calcium in larger amounts inside of the cell is really, really bad. And we'll have another slide about the deleterious effects of calcium in the cell. But calcium can be really bad inside the cell. So because we've got these, especially sodium, hanging out in a lot larger quantity inside of the cell, where sodium goes, water follows. So we have each increasing in water inside of the cytoplasm, which leads to increase in the size of the cell because we have cellular swelling occurring. Now when we start getting this increase in fluid, increase in water inside of the cell, another thing that's going to happen is that endoplasmic reticulum is going to start to swell. That nice little foldy accordion looking thing, right? As it starts to swell, the ribosomes that are attached to the surface of that, they just start popping off because their home is expanding. They can't anchor themselves anymore. When your ribosomes are attached to your endoplasmic reticulum, you stop making protein. And one of the biggest things that your cell needs on a regular basis is lots of different kinds of protein to do all the functions that your cell needs to do. So once we have protein function or protein loss of our synthesis, we start having issues with, number one, just keeping up with our normal cellular functions, and then number two, we start to get some deposits of lipids within the cell. And we'll talk more about this soon, so we'll get back to that. Okay, let's go over to the other end of the spectrum with decreased ATP. When we don't have enough oxygen, we start to undergo anaerobic glycolysis. Ultimately, that increases our lactate levels and decreases our pH within the cell. If it's a large-scale ischemic event, we now have decrease in the pH of the body. We can have some metabolic acidosis. Within the cell, however, when the pH falls, the nucleus does not like it. And the nuclear chromatin begins to clump. It's not a good thing for the survivability of that cell. All right. Sodium and water accumulation in an injured cell are a direct result of decreased ATP production, karyorrhexis, ribosome detachment, or dehydration. Decreased ATP production. We talked about ribosome detachment. A little review of some of our old things though. Karyorrhexis, which is not the correct answer, but in case you went, wait, I think I've heard that before, but what does that mean? So we've got a couple of different terms for things that happen inside of the cell when we have cell damage. They can happen together, they can be in a series, they can happen just one. Karyolysis, nuclear fading. So if you're looking at a cell under a microscope, the nucleus begins to fade. Pinosis, this is nuclear shrinkage, so the nucleus is much smaller. And then karyorrhexis is nuclear fragmentation. So if you look at that cell under a microscope, you'll see clumps of the nucleus all over the place instead of in a nice center of the cell in one distinct area. So all of these can lead to cellular necrosis. So it's a good sign that the cell is not healthy. Okay, a little bit about oxidative stress. Oxidative stress is injury from free radicals. Free radicals are electrically uncharged atoms or group of atoms. They have an unpaired electron. And that unpaired electron is desperately hunting for a match. What is this initiated by? Where do these electrically uncharged atoms with unpaired electrons come from? Well, it can be absorption of extreme energy sources, UV. If you're a sun worshiper, this is a good way to pick up some oxidative stress and then some skin cancer maybe. Radiation exposure for many sources, including excessive testing in the medical realm, because we use radiation a lot for x-rays, for CAT scans, etc. Endogenous reactions. Some of the things that our own body does on a regular basis produces a couple of free radicals. Metabolism of exogenous chemicals or drugs. So if you're exposed to something, if you take something that may lead to free radicals formed. And then reperfusion injury, which we're going to be talking about in just a moment, but we had to introduce oxidative stress first. So like I said, those unpaired electrons on these atoms are hunting down areas they want to latch on. They're lonely, they're sad, they want to be paired. So they're looking for something, and they latch onto things like the lipid bilayer. And that can cause lipid peroxidation and damage the membrane. You can have alterations in proteins because they can bind to proteins. We can have fragmentation of the DNA if it binds to elements of the DNA, and also damage to the mitochondria. So there's lots of ways that these free radicals can damage the cell. Now, most of the time when these free radicals occur, we do have mechanisms within our body to scavenge for free radicals to minimize the damage. But when we have a huge insult in certain ways, we can have a very large production of free radicals that overwhelms the body's ability to scavenge them and keep them from causing too much damage. And one of the biggest ways that this happens is something called reperfusion injury. If you have, let's look at the situation here. So we're going to pretend that this is a cardiac cell, even though this looks nothing like a cardiac cell, because number one, we're doing cardiac very shortly, and number two, it's a relatively common thing to happen. Heart attack. We've got some kind of blockage inside of a vessel that is supplying blood to a portion of the heart cells. So there's a thrombus here. We've got a clot, and anything distal to this clot that was provided oxygenation primarily through this vessel is going to start undergoing some of those, that cascade that we talked about with an anoxic injury. Now we are able to reperfuse this. Maybe the clot cleared on its own. Maybe we got the patient to the hospital quickly and we were able to administer thrombolytic therapy, clot busters. Maybe we got them to the hospital and we got them into the cardiac cath lab and we were able to do a stent or a balloon angioplasty. Either way, we have now returned blood flow to an area that had previously been deprived of oxygen. In those cells that had previously been deprived of oxygen, there's been a lot of chemicals produced by the injured cells that once we provide that oxygen back to them, we have this perfect storm of free radical formation. Damaged cells plus reperfusion equals free radicals. Now, it's still better to reperfuse than to just let them die. So this is more conceptual. A lot of the research right now, and especially in strokes and in heart attacks, is okay, we know that when we reperfuse, that we do cause some additional injury. We also know that if we don't reperfuse, the situation is much worse. So we're still going to reperfuse, but how can we prevent pharmacologically, probably going to be pharmacologically, how can we pharmacologically potentially prevent the excessive damage caused by free radicals when we have a reperfusion injury? So just understand the concept. Blood flow is cut off, bad chemicals are made, blood flow returns, free radicals form and can cause more damage.
Like damaging the actual cells that you just.
Damaging the cells that cell itself and cells that are in the general vicinity.
I mean, the cells would have been dead anyway.
Not necessarily. Remember, this could be reversible. So we could have a say, I mean, if they're just going to be dead energy anyway, then we would never reperfuse, right? So there's, someone comes to, and we're putting the cart before the horse a little bit, but since, you know, it's part of the discussion, it'll help you understand it. Patient has a stroke. We confirm that it is actually a clot and not a bleeding stroke. There's two big categories of strokes, hemorrhagic and ischemic. So it's not a bleeding stroke, it's actually a clot. And we have these drugs, these clot busters that we can give patients that can potentially break down the clot. Because we have cells that are they're gonna die no matter what. But then we have other cells that because of collateral circulation, they are salvageable. They're definitely damaged right now, but if we can return blood flow to them, they can survive. The longer the window from when the injury started to when that thrombolytic therapy is administered, the less cells you're going to save. So we usually say about a 3 to 4 hour window. If you come to the ER 5 hours after your stroke symptoms started, I haven't been able to move the left side of my body for 5 hours and now I decided to come in and check it out. At that point, we've probably lost all the cells that we're going to lose. Giving thrombolytic therapy is probably not going to do any benefit. So at that point, they usually say, nope, risks outweigh the benefits, and welcome to your left-sided body that doesn't move very well. One of the reasons why we really emphasize stroke education, if you have any kind of neurologic symptom whatsoever, even if it comes and goes away, get to the hospital, because time is brain. You may have seen some of these billboards. Time is brain. You don't wait to see if it's, oh, maybe my arm will start working again. No, get to the hospital. All right. So accumulations and cellular injury. So when cells are injured, there can be certain things that are left deposited in them. So even though that they are injured and we're able for them to not be dead, they're still doing something, there can be some accumulations of different products that stay in the cell and then can alter the overall function of the organ. One good example that may be familiar to a lot of you guys is fatty liver. Fatty liver, seen very commonly in alcoholics. Goes in hand with alcoholic cirrhosis. You get fat deposition inside of liver cells because alcohol is directly toxic to the cells of the liver, and one of the ways that the liver is affected is that you get chunks of fat that hang out inside the liver cells that contributes to the eventual decline overall of the liver. So you can have lipids and carbohydrates that are deposited within the side of the cell. The most common of these areas are the spleen, liver, and the neurons. You can have glycogen deposited in patients who have diabetes. You can also have proteins that are deposited. Yes? Within the cytoplasm, usually. Within the cytoplasm. Good question. You have water that's accumulated. So this kind of goes along with what we've talked about already, the fact that you can have increase in water because of decreased ATP. secondary to lack of oxygen. And this is reversible. So we can have a cell that either is able to be reversed, we resupply oxygen soon enough, or we can have something that happens called hydropic degeneration. If we have too much swelling, just the swelling itself can cause the cell to, we get what we call extensive evacuation, which is big chunks of water bubbles within inside the cytoplasm, going along with the ER that is distended. That can also rupture. But if we can stop it before too much of this damage occurs, it is reversible. Teresa, do you have a question?
So the free radicals, do they accumulate inside the cell, or they just cause?
The free radicals will not accumulate. So they're atomic, they're very small, but they attach themselves to things like the membrane. So it's in the process of attaching this unpaired electron, attaching to a membrane. It can cause membrane damage, which can ultimately, in large enough amounts, cause a membrane to rupture. It can attach to a protein and cause it to not function appropriately. And if it's just one protein in one place, it's not going to hurt you. But if it's multiple proteins and a bunch of cells in the same area, so it's more of an additive effect. We have constant free radicals being developed within our body. It's just when we have a huge amount of that are developed or made in a small area in a short period of time that we overwhelm the system and we can have damage that occurs. Another hand? No? Okay. So I think water is pretty straightforward, right? Water inside the cell, too much water, not so good. All right, calcium. So I told you guys earlier, calcium is not good in large amounts. Okay. So normally, calcium, if it gets into the cell, we have very small amounts intracellularly. Normally the mitochondria and the endoplasmic reticulum will kind of soak up extra calcium, so it's not hanging out inside of the cytoplasm. We also have ATP dependent pumps that pump calcium out of the cell. Not nearly important on a day-to-day, minute-to-minute basis is that sodium-potassium ATPase pump, but still incredibly important to maintain cellular homeostasis. Now, if we have a bunch of calcium that is released into the cell from damage because we have decreased ATP, so therefore the ATP-dependent mechanisms that normally either suck it into the mitochondria or push it out of the cell are no longer working. When cellular calcium raises, it initiates multiple intracellular cascades that cause a ton of damage. Really just want you to focus on this bottom part, the bottom arrows here, what ultimately is happening. Know how too much calcium happens when we don't have enough oxygen. Normally calcium's around, not too much in the cytoplasm because the mitochondria soaks it up, the endoplasmic reticulum soaks it up, and we've got pumps that push it out. When we stop having enough ATP, those processes stop. We have too much calcium inside, it initiates intracellular cascade, and ultimately we have phosphorylation of protein and chromatin fragmentation, so your proteins aren't working properly and your nucleus is being attacked. Your membrane becomes damaged. Your cytoskeleton, which maintains the structure, the physical structure of your cell, becomes damaged. Already talked about the nucleus and chromatin being damaged, and then further decrease in ATP because it also activates ATPases. So a little bit of calcium, good. Lots of calcium, no bueno. All right, so let's look at some systemic manifestations of cellular injury. So we've been talking about cells that are localized, and we've got some cells that are injured, cells that may be dying. What are we going to see from a bigger picture? What might we see in our patients? First off, fever. This can be from the release of endogenous pyrogens if you have a bacterial infection, or macrophages from any kind of infection. Could mean an acute inflammatory response. You can have generalized inflammation that increases the body temperature that isn't necessarily an infection, but it is inflammation. Normally when you have increased inflammation in the body, you have increased metabolism. So you may see an increase in heart rate. And there's some lab values that I want you to be familiar with in general. Because you're going to see these, they're going to come up. You want to know how, when you see them, what do they mean? Okay, leukocytosis. Leukocytosis, increase in your white blood cell count. This is the only number that I want you guys to know. Normal white blood cell count is 5,000 to 9,000. Anything below or above that is problematic. And this is going to be any time the body's trying to fight an infection, you can see an increase in white blood cells. Then we have some other things that we measure that help us to determine the location and extent of cellular damage. Lactic dehydrogenase, LDH. You can see, I'm not going to, once again, don't need to know what normal levels are, but you can see an elevation in LDH if you have problems with your red blood cells, liver, kidney, skeletal muscle. Excessive damage to these areas will see increase in LDH on lab values. Creatine kinase, CK, released from skeletal muscle, brain, and heart. There's subcategories that we can help to determine if it's from the cardiac tissue. So in a heart attack, we may be looking at CKMB, which is a subcategory. So we're going to be talking about these when we start talking about some of the different disease processes specific to organs. Aspartate aminotransferase, AST, released from the heart, liver, skeletal muscle, kidney, pancreas. Really used a lot to look at the liver, as well as ALT, alanine amino, it shouldn't be aminotransferase, released from liver, kidney, and heart. But once again, ALT, AST, and ALP, mostly from the liver, is the things that we're looking at. And then amylase. Amylase is an enzyme that is made only in the pancreas. If someone has increased amylase levels on their lab values, you know it's the pancreas that's causing issues. So I just want you to be familiar with these because you're going to see these in patients charting. You're going to be participating in rounds on your patient, and they're going to be like, okay, well, you know, his ALP level is up from yesterday, and you want to be able to understand in general what that means. Because they're going to talk about that in front of your patient, and then they're going to leave, and your patient's going to go, my AL, what is elevated? What does that mean? And then you have to be the one to explain, okay, this is what they're talking about, this is what it means. And please remember that it's always okay, because I will say this myself, always okay for your patients to say, you know what, I don't know what I'm going to find out for you. Because no one knows everything. And the minute you think you know everything is when you become really dangerous. So, yes? So they all have normal ranges, yes. And like I said, I don't want you to know the normal ranges. That's stuff you can look up. But if you have a, if you've got a situation where your parent, that they're saying, you have this patient has an elevated CK. Oh, okay, CK. Then you can look up, okay, I know that means there's some kind of inflammation or some kind of cellular damage going on. Now I can look that up. So you have to have a basic understanding that these are things that are released in increased amounts when we have cellular damage. And it can help us to specify an organ or area where that damage is coming from.
Are these all inflammatory?
These are all they're not necessarily inflammatory. They're all indications of damage, which usually, once damage occurs, the inflammatory process is initiated, because that's part of how the body works, is that when there's cells that are damaged, we're going to initiate some inflammation. But in general, we're looking at release due to cellular damage.
Do you see also that there's subtypes for each? So like for ALP, would you be able to see the difference between liver and bone?
ALP, I'm not sure. CK for sure, we can definitely look at subtypes. So ILP, I'm not sure with ALP. Yes?
And then you said that there's going to be increased amount
amount. Now with white blood cells, they have their own kind of thing going on. White blood cells can be decreased because of nutritional deficiencies. Someone who is incredibly ill, it's a sign that the body is shutting down and is not creating, because the white blood cells are very, very high turnover, and they're made in large volumes very quickly, and it's an overall sign that if someone has low white blood cells, that really not a good sign. Most of the rest of these, you're not going to see, where they'll be too low. It's more that we're looking at too high. Okay, so I said we'd talk about this, and here it is: necrosis versus apoptosis. So ultimately, if you have cells dying, they're going to do one of two things. They either become necrotic or apoptotic. So, basic comparisons between the two when a cell undergoes necrosis versus apoptosis. When you look at cell size, a necrosis is going to enlarge or swell. In apoptosis, it's going to shrink, be reduced. In necrosis, it's more common to see pinosis, where you have a small, increasingly dense nucleus, or karyolysis, which is nuclear dissolution from enzymes, where in apoptosis, it's more common to see just fragments of nucleus around the cell. Plasma membrane in necrosis is usually disrupted. We have rupture of the plasma membrane, whereas apoptosis, it's intact. We don't have holes in it, but the structure isn't all that great. Maybe the endoskeleton within it isn't functioning the way it's supposed to. Within the cell, in necrosis, we start having enzymatic digestion, which can then leak out of the cell and can cause damage to cells that are nearby. In apoptosis, it's intact. Chunks of things may be released in what they call apoptotic bodies, which is chunks of the cell wrapped in membrane, so they tend to not be very damaging to cells around them because it's still surrounded by some lipid bilayer, and therefore not going to be as detrimental to any cells around them. And because of that, adjacent inflammation in necrosis is frequent, whereas adjacent inflammation in apoptosis is none. Whether it's physiologic or pathologic, in necrosis it is invariably pathologic. Cells that undergo necrotic death, it's not because of a normal process, it's due to some kind of infection or decrease in oxygenation or decrease in nutrients from some other way. Lots of things can lead to this end point, but this is a pathologic process. Apoptosis is often physiologic. However, it may be pathologic, especially after DNA damage. Yes? Can single cell organisms, I left my single cell organism knowledge back in Bio 100. Kind of focused on us multicellular organisms. So, no, it's a great question, and I welcome the question. But this one, I don't know, and I'm not going to find out for you. You can find out for us. It doesn't apply to the humans. Yes? Yeah, I mean, there's this is so Tim, right? Yeah. Tim's asking us about different subtypes of apoptosis. Yes, they do exist, and Tim can tell you all about them after class. Depending on the cell and what the stimulus is, there are some different ways that cells can undergo programmed death. For the purposes of what I want you guys to understand, you just need to know the basics of apoptosis. But that's definitely something that if you're more interested in, you can look on the Google and find out. My father-in-law, he always calls it the Google. It's great. Look it up on the Google. Yudi.
Can you explain what nuclear dissolution from enzymes is?
Nuclear dissolution from enzymes. Okay. The nucleus can start to break down for many reasons, but when we have enzymatic degradation, do you guys remember the little packets of enzymatic crud inside your cell? What they're called? Lysosomes. Lysosomes. So lysosome. So you've got chunks within your cell, right? And normally they're packaged in a very tight envelope, and it's like, we don't want this to go off when we don't need it to, right? Because it's got lots of bad stuff in there, but the cell needs it for certain, emergency purposes. When we start having problems within the cell, one of the things that can happen is that your lysosomes start to rupture as well, and that can affect the nucleus. So that's when we have the nucleus that's being digested by enzymes that normally they wouldn't be exposed to. Yes?
You said that apoptosis was programmed cell death. What's the necrosis?
Necrosis is cell death in response to some kind of pathologic process. And there's just so many different ways that you can get to that it's not just, it's not like one really good description. It's the end result of either one very severe insult or multiple smaller insults, or one small insult that just continues long enough. Insult being decrease in oxygenation, decrease, physical pressure if you've got a tumor that's growing and pressing on other normal cells, an infectious process. Just think of anything that could potentially damage a cell. Sure. Oh, and this is just like a little picture of what we just talked about, so we don't have to talk any more about it for you visual learners. All right, so when we talk about necrosis then we have kind of subcategories of necrosis. So, coagulative necrosis, you're going to see in areas like the kidney, the heart, and the adrenals. Usually this is due to hypoxia, ischemia, or a chemical injury. When this occurs, the protein that's present within that tissue starts to denature. You guys know about denaturing of proteins? Scrambled eggs? I think best real world example. They're all running and then you add heat to them, the proteins denature, they solidify, and you get scrambled eggs. So not because of heat, but because of other things that are causing those proteins to denature and not do what they normally do. You start to see albumin change to a firm, opaque state. Liquefactive, often seen in ischemic injury in neurons, and we have hydrolytic enzymes that digest tissue. So instead of making it hard, we just have liquid goop that used to be cells. Caseous is usually from tuberculosis. This is a very specific type of necrosis from tubercular disease. It resembles clumps of cheese enclosed in a granulomatous inflammatory wall. Yum. Fat necrosis, you'll see in areas that have more fat. The breast, the pancreas, the lipases that are present in fatty tissue break down triglycerides, and the free fatty acids combine with ions to make soap. So you have saponification. And then gangrenous. Gangrenous is not a separate type, actually. It's actually just a large area of necrosis. So when you're looking at coagulative, liquefactive, caseous, fat, a lot of times you're talking about like a smaller area. When you have a large area that's involved, this is when you start to get gangrene or gangrenous necrosis. So you have a large area of dead cells, very often easy to become infected because when you have dead cells, you also have lack of blood supply to those dead cells and any bacteria that are in the area. We've got tons of bacteria within our normal flora. They can set up shop and really make a pretty nasty infection. Dry gangrene is usually from coagulative necrosis, so where it's more of a harder, less moist. Wet gangrene is when neutrophils invade, causing a liquefactive necrosis. And then gas gangrene is very specific to one bacterial family, Clostridium. There's hydrolytic toxins within this bacterium, causes bubbles of gas in the area of infection. Should have gotten some good pictures of those. That would have been really fun. Okay, so inflammation and wound healing. All right, when we're talking about our innate immunity, our physical barriers that we have, number one, we have our tightly associated epithelial cells of our skin, the lining of our digestive, to urinary respiratory tract. Those epithelial cells are really, really important in keeping the good stuff in and the bad stuff out. They're kind of first line of defense. The cells can slough off when they encounter something that they don't want to penetrate them. The pH of the epithelial cells makes bacterial growth difficult on the surface of the epithelial cells. So, thank goodness for that. Some of the epithelial cell-derived chemicals. What are some things that epithelial cells create that to help to just protect us in general? We've got mucus that is made, perspiration, saliva, tears, earwax. All of these can trap microorganisms and contain lysozymes that can attack gram-positive bacteria. Sebaceous glands secrete fatty acids and lactic acid that will kill bacteria and fungi. A mushroom walks into a bar. The bartender says, "We don't serve your kind." He says, "Why not? I'm a fun guy." This is the best part of being an instructor is you have to listen to my horrible jokes. No choice. Epithelial cells will also secrete antimicrobial peptides that will inhibit the growth of some microorganisms. A couple of the names of them, just to be familiar with the names, you don't know exactly what they do. Cathelicidins and defensins will disrupt bacterial cell membrane. And then lungs secrete these great little chemicals called collectins, which help to induce macrophages to recognize and kill microorganisms. You're like, "Hey, macrophage friends, come over here, get this guy. He's a bad guy." So it helps aids in recognition of anything that's not supposed to be there. Our normal flora. Oh, we're learning so much more about our normal flora all the time. It's been coming out more in recent years that some of the problems are related to obesity, maybe due to the fact that your normal flora is altered. And it alters your sense of hunger, alters the way that you digest and metabolize food. Our normal flora are non-pathologic organisms living on in-body surfaces. They are either commensal, to the benefit of one organism but not the other, or mutualistic, where both organisms benefit. Yes?
Could you give an example of the
Commensal. Let's see here.
like that? Do
That's-
those like occur within our bodies?
They occur within our bodies. I'm trying to think of a class of bacteria that may. Let's go with Staph aureus on the surface of our skin. Now we get really freaked out about MRSA, which we're going to talk about next week. Staph aureus on the surface of our skin, part of our normal flora. Doesn't really benefit us very much, though. It's just there. We know we have it. Whereas we have other bacteria, we're going to talk about some of the beneficial parts below here. Other bacteria within our body that, they gain from us, so they have a nice, warm, happy place to live. We gain from them things like this. In the GI tract, without our normal flora of GI organisms, we don't digest very well. That whole probiotic thing, right? There's rationale behind it, especially when you knock out someone's normal flora with antibiotics in their digestive tract. You get diarrhea, stomach cramping, problems with indigestion and stuff. So they definitely help us with digestion. They produce vitamin K. And we need that vitamin K to clot. And they assist in absorption of food and other products. They also will compete with pathogens. So it's like, hey, we're the normal flora here. Pathogen comes in and they're like, nope, no room for you. We already took up all the space. And the pathogens have a much harder time of doing what they want to do, which is take over, because your normal flora is there. These normal flora can help to produce chemicals. And all the seniors are here today, so haven't seen them for a while. Produce chemicals that inhibit colonization by pathogenic microorganisms. Clostridium difficile, C. diff. Have you guys heard of C. diff before? Probably heard of it just in the media. It's a nasty, nasty bug, GI bug, horrible, horrible diarrhea. really hard to get C. diff if you have a normal flora, if you haven't been on antibiotics, if you are functioning. So out in the setting of the hospital where C. diff is around quite a bit, it's really hard for you guys to pick it up. Unless you get a sinus infection, you start taking some antibiotics that alters your normal flora, or if you have some other kind of immune system disorder. But we have patients who are in the hospital who are ill, who are on antibiotics, and then when C. diff is around, they pick it up, and it just makes matters much worse. Other things that some of the ladies may have experienced. You take antibiotics as a female, much higher risk of developing a vaginal yeast infection, because you have lactobacillus in your vagina, part of your normal flora, that helps to prevent infections of the vagina and the urinary tract, especially by yeast. So once you alter that normal flora, you have increased risk of different types of infection. One thing to note is that your normal flora can become an opportunistic infection. Opportunistic infection means it's part of your normal flora, normally existing in checks and balances, and for whatever reason, usually because you're severely immunocompromised, once again, it's usually not something that just pops up in a healthy person with a healthy immune system. When we see that term opportunistic infection, that means you weren't exposed to something new in the environment. It's been part of your normal flora, but because of everything else that may be going on in your body, maybe you have AIDS, maybe you are on high-dose immunosuppressants because you have an autoimmune disease. For whatever reason, now your normal flora has turned on you. Well, here's just a little pictorial overview of different areas where we have just innate immunity, things that our body doesn't really have to think about, and helps to prevent things from getting in that shouldn't be getting in. Okay. Inflammation is programmed response to damage in the body. It is the first response to injury. It occurs with any vascularized tissue. It is rapid. It depends on cellular and chemical components, and it's non-specific. It's going to respond the same no matter what the insult. So if you get a burn, or you get a bee sting, or you take a medication that's nephrotoxic and it damages some kidney cells, the general process of inflammation is going to be the same. The size of the effect may be different. The consequences may be different. Inflammation on your skin is going to be a little bit different than inflammation within your kidney. But the basic cellular components and the series of events is going to be the same. So in inflammation, some of the things that we're going to be seeing, number one, vasodilation. When you dilate vessels, especially in arterioles and capillary beds, you're going to slow velocity, so the blood's going to be going through more slowly, and the volume of the flow that's going through is going to increase. And this is good because when things are going more slowly and with a larger volume, things within the bloodstream, like white blood cells and inflammatory components, can get to the area where it needs to go. Going along with that is increased vascular permeability. At the capillary bed, the endothelial cells that are present there start to contract. They're not constricting the vessel, they're contracting themselves so that spaces open up wider between the cells. This allows fluid to leak out. This is called exudation, and it can result in edema or swelling. The increased concentration of red blood cells in the area causes erythema or redness and warmth. White blood cells are able to adhere more easily to the vessel walls in the area and migrate through the capillary bed to where they need to go. So, make sure you have a handle on these symptoms of inflammation. You probably realized what they were as a much younger person, just because we've all had this happen to us, right? You stub your toe, this happens. Most of our experiences with it have probably been more external, closer to the surface. Same things are happening inside of the body when you hurt something on the inside. It's not quite as evident though, right? You can't really tell if your liver is red after you went binge drinking last weekend. If it's hot, if it's swollen, might be some pain, and might be some loss of function. But in general, we're looking at these 5 things. Erythema or redness, heat, so if it's close enough to the surface of the body, you can feel, oh yeah, it's warmer than the other side of my body. Or we always like to compare bilaterals, right? Edema or swelling, pain, and loss of function, either partial or total. So keep those 5 general symptoms of inflammation in mind. What are the benefits of inflammation? Why does this happen? Why does our body decide to do this all the time? Well, it prevents infection and further damage. The influx of plasma will dilute any toxins that are present. It will activate our plasma protein systems, which we'll be talking about more in this lecture. It brings in cells that will directly destroy infectious agents. So if it wasn't an infection initially, it's preventing it from happening, preventing any damaged cells from developing an infection. It limits and controls the inflammatory process. The influx of certain types of plasma proteins, especially clotting proteins, and certain plasma enzymes that will localize the response. So as long as everything else in your body is going smoothly, you're not going to get systemic inflammation. You're only going to get inflammation in the area where it's needed. It interacts with components of the adaptive immune system. This allows us to get a more specific response. So if we are exposed to something that we've been exposed to before and have preformed antibodies, or exposed to something that we've gotten immunized against, then we can tell our cells on the adaptive immune side to start doing their thing and do the specific response to a subtype of organism. The inflammatory process also prepares the area for healing. So it's looking ahead. It's saying, okay, once we get rid of this bacteria, once we get rid of this necrotic group of cells, we're going to need to heal, so dead cells and bacteria products can be removed and healing can initiate. All right, we're going to talk about 3 plasma protein systems that I really hope that you guys have at least heard of before. Maybe you've got a really good handle on them, but we're going to be talking about how they relate to inflammation and how the body responds to cellular damage. So first off, our good old complement system. You guys have all talked about complement before? Heard of complement? Okay. Huge number of proteins within our body. 10% of our total serum proteins. We always think albumin, and albumin really is the biggest chunk. But 10% of our serum proteins are proteins making up our complement system. And it's a complement pathway that you have these different ingredients of complement floating around all the time. And it only is when one of them becomes activated that it initiates a cascade, which results in a couple different things going on. So we're going to go over the really important parts. We're not going to go through the entire complement system. There's a couple of different ways that the complement system can be activated. Don't worry about that. We're just get to the point where it's been activated. There's something inflammatory or infectious that's going on that has signaled the proteins to start to become activated. And it all starts with C3. C3 is floating around doing its thing. Happy, and then something tells it, warning, we need some help here. So it's going to activate it. Once C3 is activated, it actually fragments to 2 pieces. And those 2 pieces split off and start doing a couple different things. One, C3A. It's an anaphylotoxin. It means that it helps to attract more cells to the area. And it also stimulates mast cells to degranulate. And we'll talk more specifically about mast cells in a little bit. C3b, the other half of C3. is going to directly bind to surface of the cells, a process called opsonization, which increases their susceptibility to immune cells. So it has a cell that it's binding to saying, hey, immune cells, you need to take care of this cell right here. It's putting a flag in it, making it more visible to the other immune cells that are around that can help to destroy it. Do you have a question?
Yeah, what's
Anaphylotoxin is, it will increase the signals for more immune cells to come. C5a, also an anaphylotoxin, chemotactic will attract neutrophils. So that comes from C3. When C5 splits, C5b will join up with C6 through 9 and join the membrane attack complex, the MAC. Bind onto a cell, it'll actually make a hole inside of the cell. It makes a pore in a cell that needs to be destroyed. Usually it's a cell that is either a bacteria itself or a cell that is infected by a virus. But sometimes it is a cell of our own that needs to be destroyed for whatever reason. C5a, like I said, when C5 splits, is going to increase our leukocyte chemotactic transference. So it's going to signal other white blood cells to come to the area. Okay, so in summary, what does the complement system do? Number one, opsonization. It creates a red flag that signals other cells in the immune system that a cell needs to be destroyed or attacked. It has anaphylotoxic activity, which is pro-inflammatory, causes the release of other chemicals like histamine, and stimulates mast cell degradation. Like I said, we will talk about mast cells. Leukocyte chemotaxis, sending out all points bulletin, hey, any leukocytes around here, especially neutrophils, those are your first responders, get here, we need some help. And then that membrane attack complex can cause direct cell lysis, can cause cells to rupture. So very important little group of proteins that normally float around not doing much until they're activated. All right, clotting system. We're not going to focus on the clotting system too much because we will talk about it more when we talk about blood disorders. But clots will plug damaged vessels to stop bleeding. So if you have bleeding in the area because of vessel damage, whatever is causing this tissue damage, it will trap microorganisms, those clots, so it will help to prevent microorganisms from becoming a systemic infection. It also provides the framework for future healing, provides the scaffolding so that we can repair tissue. The clotting system is activated by substances that are released during cell injury and infection, and also by bacterial products. And the products will increase inflammation response, will also enhance chemotaxis and vascular permeability. So know that when you have your clotting system, your end product is fibrin. The kinin system is very closely interacted within the clotting system. Both can be activated by factor 12, which is called Hagerman factor. So part of the clotting cascade, a signal from a damaged vessel wall can also signal the kinin system. And our final product of the kinin system is bradykinin. When bradykinin is created in response to damaged tissue, that damaged tissue initiates a cascade. Final product, bradykinin. Bradykinin will dilate blood vessels, will act with prostaglandins to induce pain, will cause smooth muscle contraction, and increase vascular permeability. So you're seeing some redundancy here, right? Seeing a lot of like this, okay, we need to get more blood flow, we need edema, we need get some pain. It's telling you to take it easy on the area. So when we're looking at these plasma proteins, these three groups, the clotting, the complement, and the kinin systems, they interact with each other. They're very closely regulated. And when we have dysregulation, we can have disease processes in and of themselves. If you have chronic inflammation of unknown reason, that can be a disease process. But in a normally functioning immune system, very tightly regulated because we want them to act fast and act with a great deal of strength when we need it, but we want it to be incredibly limited and not do this all the time. All right, let's look at some of the individual cellular components within inflammation. Cytokines. Cytokines is the name for molecules that will affect other cells, and we have over 100 that have been identified. They can be pro-inflammatory or anti-inflammatory. Remember I said everything is a checks and balance, right? If you have the ability to initiate inflammation, you also want to have the ability to have a system that works against inflammation, because too much inflammation is bad. Cytokines can diffuse over short periods, bind to target cells, and can affect cellular function. Some can have even further reaching effects. For example, endogenous pyrogens, which are in the category of cytokines, can induce fever, which will have that systemic febrile response. So while there are over 100, there's just a couple I want to make sure that you guys have an understanding of. Okay, remember we're talking about little chemicals, little molecules. Most of them are produced by components of the inflammatory system that are released in response to a stimulus. Interleukins. Interleukins are a class of cytokines that are produced by macrophages and lymphocytes. And they're released when there's stimulation by pathogens, by products of cellular damage, or by other cytokines. So they don't just manifest for no good reason. There's some kind of stimulation that causes them to be released. The effects of interleukins. Alteration of adhesion molecule expression. So adhesion molecules aid in the ability of our immune system cells to adhere to either our own necrotic cells or chunks of necrotic cells that we want to get rid of, or bacterial viral cells that we're trying to destroy. Attraction of leukocytes, chemotaxis. Induction of proliferation and maturation of leukocytes in the bone marrow. So that's when you're going to start to see that white blood cell count go up. Stimulating the bone marrow to make more white blood cells because there's something that they need to do. General enhancement or suppression of inflammation. Yes?
So they're produced by macrophages and lymphocytes and then stimulate more to come to
Yep.
a specific area?
Yep, so yes, so they're made by some cells and then stimulate more different types of cells to come to different areas, yeah. So basically these are our first, maybe the first responders, well no, it's the neutrophils. So this is at the localized first responders. The neutrophils are your systemic first responders. So if you have an infectious process going on, we can look at a general white blood cell count, but we'll often do a differential white blood cell count where we look at the neutrophils, the eosinophils, break out our white blood cells, so differentiate. And when you have that first bump of neutrophils, that means it's an emerging or new infection. Neutrophils levels start to fall, and then we have other cells that start to predominate. So some specific interleukins that I want you to be familiar with. Interleukin 1. It's produced by macrophages. It activates monocytes, other macrophages, and lymphocytes, and acts as a growth factor. I should say stimulates, not stimulated. Stimulates chemotaxis, so encourages other cells in the immune and inflammatory area to come in, and the proliferation of immune cells. And something big to recognize about IL-1, interleukin-1, is that it's an endogenous pyrogen. So interleukin-1 is very strongly correlated with having a elevated temperature or a fever. Interleukin-6, produced by macrophages and a couple others. It induces the hepatocytes to produce something called acute phase reactants, and we're going to talk about those in a minute. Also stimulates the growth of blood cells and fibroblasts for wound healing. So very important for the healing process after we attack the initial issue. Interleukin-10, produced by lymphocytes, and it actually suppresses the inflammatory process. It's an anti-inflammatory. So interleukin-10 is kind of on the other end of the spectrum. Maybe we've addressed the initial issue. It's like, okay, time to calm down. Had enough inflammation. Let's back off. Tumor necrosis factor alpha, secreted by macrophages and others, often in response to cancerous cells, but not always. TNF alpha is highly inflammatory. It will induce fever. It will increase the synthesis of other inflammatory mediators, and it actually puts the body into such a high metabolic state that if you have high TNF alpha levels for a long period of time, you can have muscle wasting. High enough amounts are deadly. In fact, part of the reason that cancer is deadly is due to the massive amounts of TNF alpha that are being produced. Interferons, very important to know about interferons because they protect against viral infection. They signal nearby cells to produce antiviral proteins. So I've got a little picture of this here. So this initial cell is infected with the virus. And he's like, no, it's too late for me, but save yourself. And he tells the other cells, like, this is what you need to do to keep this virus from getting to you. So it kind of passes off an instruction to their friends, their cells around them. This virus is around, this is how to keep it from getting in, and now this antiviral protein is able to block the virus from being able to replicate within the cell. So interferon is very important in the body's endogenous method of controlling viruses. And then chemokines. We've talked about chemotaxis a lot. Chemokines are what cause chemotaxis. They are very tiny little cytokines that attract leukocytes. Send out a chemical signal, and any leukocytes in the area are going to be drawn to an area where they're needed. So I don't want you to get too worried about this slide, but I like to see kind of like the basic ideas of what do cytokines do. So some of them do vasodilation, and here's a list of a couple of them, ones that you probably recognize like prostaglandins and histamine. They increase vascular permeability, histamine, bradykinin, leukotrienes, pain, some systemic effects like fever, leukocytosis, acute phase reactants. Remember, the only ones I want you to know are ones that I specifically talk about, not this whole chart. Limiting inflammation. So we've got a couple that limit inflammation, a couple that help with immune response, some that help with repair and healing, and some that help with phagocytosis. So kind of an overview, that's why I put this on here, an overview of some of the different functions of cytokines, how important they are to the inflammatory process. Okay, 65-year-old female is diagnosed with metastatic breast cancer. She has developed muscle wasting. Which of the following substances would be produced in large quantities to eliminate the tumor and to cause the muscle wasting? There you go, tumor necrosis factor alpha. All right, a couple of other types of cells. Mast cells, most important cellular activator of inflammatory response. They're found in loose connective tissue, just kind of hanging around close to blood vessels and near the body's surface. Basophils are found in the blood, and they function similarly. And when they are stimulated, when they're just floating around doing their thing, not being stimulated, they're inert. They're just there. But when they're stimulated by something that is going on with the cell, with cellular degradation products, with any chemicals that are released that go along with cellular injury, or with some kind of infection, there are contents that are released, and they shoot out degranulations. They're called degranulation because it looks like little granules. If you look at them under a microscope, they got all these little envelopes filled with chemicals that when they release will do things. So, histamine, vasoactive protein. You guys have probably taken antihistamines before, Benadryl. We have some of our second generation ones like Claritin that aren't quite as drowsy. It's a vasoactive amine, causes rapid constriction of smooth muscle and dilation of venules, leading to increased capillary bed blood. This will lead to ultimately increased vascular permeability. It also has chemotactic factors, once again, encouraging more different types of blood and chemical mediators to come to the area. Mast cells also begin new synthesis of a couple things, and don't worry about this nice little picture of it. It's just kind of once they degranulate, they start a whole cascade of things that end in one, leukotrienes. They're like histamine, but they're slower and have a prolonged result, so similar action. But histamine, when it's released, it's going to have a big boom and then disintegrate. Leukotrienes kind of follows along on the back end and keeps up the vasodilation at the capillary bed and the increased capillary permeability. Prostaglandins are also made, and these prostaglandins will also increase vascular permeability, so you have more leaky capillary beds, will stimulate chemotaxis, and will also stimulate pain nerve endings. So this is the source of some of the pain that goes along with inflammation. Also created is platelet activating factor. It can function like leukotrienes in that it causes endothelial cell retraction so that you have more leaky capillaries. Also causes leukocyte adhesion to endothelial cells and platelet aggregation. So we're stimulating some of our clotting factors. And then that endothelium, those endothelial cells, the cells of the vessel wall that adhere to the underlying matrix of connective tissue. So important throughout our body, these endothelial cells. They don't get the glory that they deserve. They regulate the circulating levels of inflammatory mediators and prevent spontaneous activation of the clotting system, which would be not good at all. Nitric oxide and prostacyclin, PGI2, made from arachidonic acid, will help to maintain blood flow and inhibit clotting. When the endothelial cells are damaged, the underlying matrix below the endothelial cells is exposed. Once that is exposed, then we start to have some clotting and some inflammation occurring. So whenever we have damage to endothelial cells, which line blood vessels and digestive tract and so many other areas of our body. Platelets, cytoplasmic fragments from megakaryocytes. You guys know about platelets, right? I don't have to go too much about them. They circulate in the bloodstream. They're activated by products of tissue destruction, and they will interact with components of the coagulation cascade. Also will degranulate and release chemical mediators such as serotonin, which will act very similarly to histamine. Now, serotonin in the central nervous system we think is kind of like a calming, happy neurotransmitter, but when serotonin is in the bloodstream, it actually works like histamine as far as causing some increased capillary permeability. Platelets will also release growth factor that will help with healing after the initial inflammatory response has died down. Phagocytosis, a process by which cells ingest and dispose of foreign material. The neutrophils and the macrophages are the most important. So, cells must leave the circulation and migrate to the site of inflammation. Normally the cells can't leave very easily. So luckily we have all of that leaky capillary system going on so that these cells have a little bit easier of a time of getting out. The products of inflammation increase cell adhesions or the stickiness of those cells so that once they get into the tissue they can travel to the area under the influence of chemotaxis. So we've got 5 steps of phagocytosis. Recognition and adherence, there's a picture going next. Engulfment, formation of phagosome, fusion with lysosome granules, and destruction of targets. So next picture should be here. Yes. So really with phagocytosis, it works best when it's opsonized by C3b. So we've got some opsonization going on from our complement system. And these cells are able to recognize and bind to and actually suck into the cell, eat it up, and then lysozymes that are present within these cells will digest them. This is all stuff that you've seen before, right? This type of slide, yeah. Okay, we'll keep going then. Neutrophils, like we've said multiple times, you've probably heard it before, even this class, they're the first responders. They have a very short half-life. They become the components of pus. So when you see some pussy, purulent material, a lot of it is probably due to the neutrophils that were present. Monocytes and macrophages. Monocytes are produced in the bone marrow and circulate in the bloodstream. And they migrate to a site where there's inflammation, and they develop into macrophages after about 24 hours. And they'll start to replace the neutrophils as the predominant cell in the area. So neutrophils first, monocytes go there, and then they transform into macrophages. They're better suited for long-term action. They will divide and they will survive longer so they can continue to stay and do the things they need to do to rid any cellular debris, rid any infection, and therefore allow healing to occur. And they will help to orchestrate wound healing by phagocytizing debris, eating up both bacterial cells, viruses, chunks of stuff that shouldn't be there, promoting angiogenesis, the formation of new blood vessels, releasing cytokines and growth factors, activating fibroblasts, and promoting synthesis of collagen. Eosinophils, mildly phagocytic, primary are defending you against parasites. So we usually see increased eosinophils when we have a parasitic infection versus bacterial or viral. And then dendritic cells are the link between the innate immunity and the acquired immunity, and they will interact with our T lymphocytes. This is a long lecture, huh? How many slides are left? Jeez. All right, I only got a couple more minutes left in me, guys. All right. Acute and chronic inflammation. I thought we were getting to wounds already. We're going to acute and chronic inflammation. Okay, local manifestations of acute inflammation. We already said edema, pain, heat, erythema, loss of function. Then we have our different types of exudate, which you guys, I think, mostly absorbed last week when we were talking about different kinds of wounds in lab. I think probably the only one we didn't talk too much about is this fibrinous, which is with severe or advanced inflammation. It's thick. So if you have severe inflammation but it's not purulent, you can't have some kind of chunky inflammation that's not due to an infection but is due to very severe inflammation. The rest of them are pretty straightforward. I think you've seen them all before. Systemic manifestations of acute inflammation, fever, talked about it. Leukocytosis, greater than 10,000. Plasma protein synthesis. Oh, here we go. Here we have our acute phase reactants. I promised you I'd talk about this. So, acute phase reactants are produced by the liver. They're a group of proteins that are made in response to systemic inflammation. Some of these are C-reactive protein. You can do blood levels of this, see if someone is having an acute inflammatory response. Our complement proteins. Those complement proteins that are normally circulating, they're 10% of our circulating proteins. And fibrinogen are created. And a lot of these chemicals will increase our erythrocyte sedimentation rate, or ESR. So ESR is a blood test that we will do. So you'll hear just called the SED rate when people are talking in short term in our nice little medical lingo. So SED rate, the erythrocyte sedimentation rate. When you have someone who's not having any kind of inflammation or systemic inflammation going on, and you drop some of their red blood cells into a tube, when things aren't circulating, the red blood cells will slowly fall to the bottom of a tube. That's the sedimentation rate. Okay? When you have inflammatory mediators, cytokines, all the chemicals that are involved in inflammation, cells get more sticky, and that includes the red blood cells. and your sed rate is going to be a smaller number. It's the amount of time it takes them to settle, because they're clumping together, and because they're clumping together, they make heavier molecules. Instead of one red blood cell that's floating gently, now it's 4 red blood cells that are stuck together, they fall faster. So especially when we're looking at someone with, we're trying to diagnose them, they're having some general signs and symptoms of inflammation. It's a relatively non-specific test, the ESR, the sedimentation rates. But it's good not only to determine, yes, we do have some sort of inflammation going on somewhere, but also to track that inflammation. Is what we're doing making things better? So of course you'd need serial sed rates to be able to see that. Chronic inflammation is inflammation that lasts longer than 2 weeks, characterized by dense infiltration of lymphocytes and macrophages. A granuloma can form where the body actually walls off and isolates the infected or inflamed area, which is a good thing. It's a nice mechanism to wall off areas of things we don't want to have to deal with all the time. The classic example is tuberculosis, once again. So can we pick up wound healing next week?
Yeah.